Alrighty, so again, we're talking about the anterior approach to hip replacement, which is, again, one of the major advancements in how we do hip replacement now. And we're also going to cover some other things that, again, have taken it from a surgery that you spend 3 nights in the hospital and we're in a lot of pain to something that we're doing same day. In fact, I did one this morning at our surgery center, and she's home and doing well right now. So quickly about me, I'm an orthopedic surgeon, and a lot of people nowadays, we do fellowships after the general orthopedic training. And so my fellowship training was in adult reconstruction, which is essentially hip and knee replacements, and then also the revisions and kind of the advanced complex work that sometimes we get into with deformity work. But really the bread and butter is hip replacements and knee replacements, and I can take care of problems related to those. My family there on the right, 2 kids and my beautiful wife. So I did my training, my medical school training at Jefferson in Philadelphia. Did my residency at Geisinger, which is also in Pennsylvania, and then went out to Utah for my fellowship, which again was to focus on hip and knee replacements and revisions. And so now I'm here at Ortho SC. Been here for about 4 years, and I'm mainly out of the Carolina Forest office and operate at Grand Strand Regional Medical Center. And again, what I do is hip replacements and knee replacements and some of the complex surgery associated with that. So briefly, what we're going to talk about, we're going to get kind of the basics. What is arthritis? What are the things we can do from a non-operative standpoint? What are the surgical treatment options for it? And then again, kind of the real reason we're here is to talk about anterior approach hip replacement, and then some of those modern advancements. Templating, I think, is really important. How we control pain, how we control blood loss, and kind of how we put all that stuff together to make this an outpatient surgery. So what is arthritis? Arthritis specifically means inflammation of the joint. Itis means inflammation. The prefix arthro means joint. And so this is just inflammation of the joint. Most of the time, this is due to loss of the smooth articular cartilage that covers the end of the joint. So on this picture here on the right, you can see there's loss of that blue cartilage cap. There's bone exposed that causes grinding, inflammation, and pain, and that's what causes the arthritis pain. So 2 pictures here. On the left, we have a normal hip, and on the right, you start to see these bone spurs and erosions where there's none of that smooth cartilage. Another diagram here where there's smooth cartilage, and then cartilage gets worn away as arthritis advances. This is an actual picture from a surgery. That's someone's femoral head, and you can see there's a big old area here where there's no cartilage left. There's some areas where the cartilage has been worn down as well, whereas a hip that was not done for a femoral head that was not removed for arthritis, there's plenty of that smooth, glossy cartilage. Looks kind of like the end of a chicken bone. That's normal cartilage. So on the x-ray, we definitely use x-rays in clinic a lot to try to determine what's causing your pain. If there's a space between the bones there, that's called a joint space, and that isn't just space, it's cartilage. And that's what a normal healthy hip looks like. And on the right, there's no space there. That's what we call bone on bone. We actually see the bone contacting the bone. And what that means is if there's no space, there's no cartilage. That's really bad arthritis. So what causes arthritis? The main thing is genetics. If you have family members, brothers or sisters or parents that have required joint replacement, you're much more likely to require that as well. Age, certainly as you get older, that starts to catch up to you and the cartilage will wear out. Obesity definitely has a role as well. If you're overloading your joints, the cartilage can only take so much and it will start to wear out as well. There's a bunch of other reasons too. Trauma is one of them. There's some other crazy problems that cause premature cartilage damage, but the main reason is if your parents had it and if you're getting older. And again, this is kind of a wear and tear process. It's a degenerative thing that just gets worse with time. So for the hip arthritis, the main thing that we look for, the main symptom that we're going to ask about is groin pain, and groin pain that gets worse with activity. So if you sit on the couch and do nothing, it's probably not going to bother you too much. But as you're moving your hip more and more, you're using your hip more and more, you're going to grind that bone against bone, and it's going to cause that inflammation and pain. Stiffness is another finding. In fact, stiffness is often the first finding, where you notice that you can't really get down to put your socks and shoes on. You're having trouble getting out of your car, which really requires a lot of hip flexion. Sometimes we'll see catching and locking. And as a rule, a groin sprain, that gets better in a couple of days. But if you have a groin sprain that's really just not getting better, it's been a couple of months and it's just not getting better, maybe it's getting worse with time, that's very concerning for hip arthritis. So on our exam, the main thing we're looking for is that groin pain. And we try to elicit that groin pain by trying to move the hip joint. So in this picture, the woman is flexing the hip up and she's going to start rotating it in and out to move that hip joint around. If that causes you a lot of pain, that's really concerning for hip arthritis. As you get more advanced arthritic changes, as you start to wear down the bone in addition to the cartilage, you get joint contractures where the hip won't actually come all the way down on the table. Sometimes you have a leg length inequality because you've lost that cartilage. Your hip's a ball and socket. You've worn through that cartilage. The whole leg will shorten some. And those are some of the late findings that we see on physical exam. And again, as I mentioned, the x-ray is really important. We'll often get the x-ray before we even see the patient to kind of clue us in as to what's going on. If we don't see any joint space, that's a bad sign. That means you've got arthritis. So the non-operative options, it's pretty straightforward. It's pills, shots, a cane, weight loss, activity modification, right? All that is probably a lot of stuff that you've done by the time you've seen us, right? So by pills, what we mean are anti-inflammatory medications. So the over-the-counter medicines are medicines like Aleve or Advil, and you can certainly get the generic version of this. There's prescription strength anti-inflammatory medicines as well. They go by the names of Celebrex or meloxicam or diclofenac. They're really all the same family of medicines. Sometimes they work better for one person or another person. So you really just find what works best for you. Again, all you're doing really there is reducing the inflammation in your hip. You're not changing anything with the actual cartilage itself, but if it makes you feel better, that's really what we care about. And then Tylenol is a different family of medicine. You can take Tylenol with anti-inflammatories, or if you have kidney issues or stomach ulcers, then you really want to avoid non-steroidal anti-inflammatories like Aleve, and Tylenol is going to be really the main thing to rely on. So medications that you want to avoid, really narcotics, hydrocodone, oxycodone, morphine, these are all medicines that, we know that these are bad medicines for lots of reasons, but I mean, the main reason from an orthopedic standpoint is they don't really work on your hip. Aleve is going to reduce inflammation in your hip. Oxycodone is going to numb your brain. And so, yeah, you won't have pain, but it's not really working on your brain itself. There's other medicines, what we call dietary supplements or vitamins and minerals like glucosamine and chondroitin, osteobiflex, those kinds of medicines. These are all medicines that aren't really FDA regulated, but they have been studied to some extent, and they can definitely make you feel better. Don't fool yourself to think that glucosamine and chondroitin, which is a building block of cartilage, is going to go into your stomach, get broken down into the smallest building blocks, and then magically on the other side of your intestine turn into cartilage again. It's not going to do that, but it works probably on par with Celebrex or Tylenol. So if it's something that works well for you and it doesn't cause side effects and it makes you feel better, then by all means, go ahead and use it. We know that it's safe. That brings us to injections. Injections are definitely something we use a lot for knee arthritis, shoulder arthritis. It's not as commonly used for hip arthritis, mainly because the hip joint is really deep down in there. It's far enough under the skin that it's not something that you can do just blindly. You need either X-ray or ultrasound guidance to make sure that your needle is getting in the right spot. Really the only kind of injection that you can do is the steroid shot. There's some gel shots for knee arthritis. That's not approved for hips. So it's really just a steroid shot. And I tend to use steroid shots for the hip more as a diagnostic tool than anything else. You definitely can get some relief from it, but we really want these shots to work for 3 months or more. And it really only does that for mild arthritis. So again, I tend to use it for if we're having trouble figuring out where your pain's coming from. If we numb up your hip joint and your pain goes away, that really helps us in determining that, yeah, that's probably where your pain's coming from. I sometimes tell people that, with that injection, right after the injection when your hip's numb, that's kind of how a hip replacement feels. So if it helps you a lot, you probably would benefit from a hip replacement. If it doesn't help you very much, yeah, maybe a hip replacement is not going to fix your pain generator. Weight reduction and cane use. The hip is off center from the center of your body. So when you transfer your weight from one side to the other, your hip has to balance that and actually sees several times your body weight. So if you're overweight, even a small reduction of your weight can decrease the joint reactive force by quite a bit. Using a cane also has that same kind of effect. A cane in the opposite hand balances that offset from the center of your weight. And that reduces the force. It doesn't reduce the actual, weight that your hip sees, but it reduces the joint reactive force that the joint actually sees because it's not centered in the middle of your body. This is a diagram that kind of goes over that. That's something you learn in training. You don't really have to memorize any of that stuff. It just goes to show you that it's a little bit more complex than just 1 times your weight. It's actually 5 or 10 times times your weight, depending on your activity. And I have to talk to people about weight reduction all the time. It's hard, if you're coming to see me because your hip is really painful and you're considering surgery for it, it's probably not a hip that you're going to be able to lose weight through exercise. It's not something that you're going to be able to run 3 miles a day like maybe you used to. So really, it's just through calorie reduction. That's the best way to do it. Diet, get a dietitian, get on some kind of weight loss program. If you stick to it and you reduce the calorie intake you should be able to lose some weight. And then activity modification, arthritis is painful, but, just by walking, doing whatever you want to do, playing golf, you're not actually accelerating the arthritis. You're not actually making the problem any worse. All you're doing is causing yourself pain. So you can do all these activities and it'll be painful, or you can not do those activities and it won't be painful. And so really that is just something that you can tinker with. Well, if I'm used to golfing 3 times a week and it's really painful after I golf, maybe reel it back to once a week. And if you're happy living that way and that's able to control your pain with changing certain activities of your life, that's a good way to try to avoid surgery. So some things that I haven't mentioned, I didn't mention stem cells and I didn't mention PRP, mainly because there's not really great orthopedic evidence that that's going to do really anything, even in the short term or the long term. So stem cells in particular it's becoming more popular, but not really with orthopedic offices. It's not founded in science. We certainly can grow cartilage in a petri dish. We can use stem cells to grow cartilage, but arthritis is a lot more than just pure cartilage loss. Again, we talked about the joint contractures, particularly with knees, the knee will bow in or bow outward. A stem cell doesn't know to grow cartilage in this area and stretch out this ligament and then tighten this ligament. And there's too much involved with that. And so I think you'll find that insurances don't cover them. They're really expensive, and the people that you find doing them probably are less interested in making you feel better and more interested in selling you more stem cells. So again, that's not something that's part of my practice. And then when non-operative treatment fails, that's when we talk about hip replacement. So we're going to start talking about hip replacement and some of the advancements now, but if anybody has any questions regarding the non-operative treatment of hip arthritis or what hip arthritis is or any of those things, you can send those questions through. And I'll see if I can figure out how to figure that out, to look at that. I don't see anything on this Q&A thing, so we'll just keep moving ahead. All right, so what is a hip replacement exactly? Again, your hip is a ball and socket joint, right? You have a normal ball and a normal socket, and the hip replacement really tries to accomplish the same thing. It tries to give you a new socket and a new ball that doesn't have that bone-on-bone grinding. So there's 4 parts to a hip replacement. There's 2 parts that actually contact the bone. There's this region we call the acetabular shell. That's made of porous metal, usually titanium, that actually contacts the acetabulum side, the cup side. Your bone will grow into that. And then there's a stem that goes into the femur bone here, and your bone will grow into that too. Again, those are the only 2 parts that actually touch the bone. The 2 parts that are moving together, the 2 bearing surfaces, are this plastic liner. It's made of highly cross-linked polyethylene, and then usually a ceramic femoral head that goes onto the stem. So the metal parts contact the bone. The the ceramic and plastic parts are the parts that are moving together. That's the bearing surface. So what do we actually do? Pretty straightforward. We take your old ball, we cut it off and throw it away. We ream out your socket to give you, really to prepare the bone to accept that new acetabular shell. We put that shell in, we put the new liner in, we prepare the femur to accept the stem, put the stem in, put the ball on top of the stem. So again, 4 parts. You're putting in a metal shell that the bone will grow into. You're putting in a metal stem that the bone will grow into. And then you have the bearing surfaces that snap into those 2 areas. And that's how all hip replacements are done. Revision hip replacements, big deformity cases, really regardless of the problem, that's what you're doing to replace the hip. What we didn't mention though was how you actually got down to the hip joint to do that surgery. We didn't talk about any of the rehabilitation required. We didn't talk about any of the restrictions, pain management, any of the advancements that, if you asked someone who had their hip replacement done in 1995, it was still done like that. It still had those 4 parts. and by and large, it's still the same surgery. A hip replacement from 1995 kind of looks similar to a hip replacement now, at least on X-ray and looking at the parts. But again, we've made a number of strides in terms of how we get the parts in, less traumatically, and lots of other stuff. So again, the hip replacement from 1995, or what we would say old school hip replacement, really large incisions. The instrumentation wasn't very good, so we kind of had a hard time getting the parts where we wanted them to be without making the incision a lot larger. The dissection was pretty extensive. You know, this picture here on the side, it's kind of making a joke about the zipper and a big large incision there on the back. But I mean, if you see someone's hip replacement from the early 2000s or mid 2000s, that's what it looks like. You would lose a lot of blood. You would need a transfusion. In fact, when I was going through med school, we would transfuse patients ahead of time. Or excuse me, they would donate their blood ahead of time, 2 units, you know, let their blood stores build back up, because we knew after they had their hip replacement, they were going to need a transfusion. We'd give them their own blood back. Sometimes we would limit their weight bearing. Early on with hip replacement, we didn't know if you could allow the patient to walk on it right away. And so as that bone was growing in, we said, oh, don't walk on it. We got to let it heal in first. Uniformly, it was done through the posterior approach. That means cutting through the butt muscle and taking down the stabilizing structures of the hip. We used smaller femoral heads that were more prone to dislocate. So we said, you can't cross your legs. We got to put a pillow between your legs. You can't bend forward, all for fear of the ball dislocating out of the socket. And then how we controlled pain was just give you a lot of morphine. I remember being in residency, we would do a bunch of hip replacements or knee replacements in a day. And if someone had pain, we'd say, all right, well, they need more morphine. And I was on call for 30 or 40 people in the hospital. And again, if they were still in pain, Mrs. Jones is still in pain, she needs more morphine. All right, we'll get her more morphine. And that's not really a good way to control pain. We've come a long way with controlling pain besides just, again, numbing your brain, not working on the hip itself. So the posterior approach, again, this is still an approach that I utilize. I use it mainly for big revision surgery when we have to see everything. And there's definitely some pros to the posterior approach. I mean, it's extensile. Again, you can make that incision from the very top of the pelvis all the way down to the end of the knee, and we can do some pretty large revision reconstruction through this. And again, that's kind of the only area that I really use that for anymore, because there are definitely some downsides to it. This is a picture actually from an orthopedic textbook. And that arrow is telling you where to go. Step number 1 is cut right through the butt muscle. That butt muscle is innervated by it's innervated by 2 nerves, but one main nerve does both sides of it there. And so you're going to de-innervate the muscle there. And even through mini incision posterior approach hip, you have to cut through that gluteus muscle. And that muscle is really important for standing up and doing stairs and important things. The next step is you take down these stabilizing structures of the hip and you open the capsule from the back. Those stabilizing structures are there for a reason. It's meant to keep the hip reduced and stable. And although you repair them at the end of the case, it's still not quite the same as if you hadn't disrupted them at all. And then the next step, which I didn't show here, is we actually dislocate the hip to remove the femoral head and do the surgery. And so that's a pretty traumatic thing when you think about it. And again, if we worry about dislocation or the ball popping out of the socket after surgery, well, I mean, if you've done it to do the surgery, it's definitely possible for that to happen again. And so there's definitely a higher postoperative dislocation risk when you do this approach compared to the anterior approach. So afterwards, you have to follow posterior hip precautions. These are things that we want you to try to avoid so that you don't dislocate your hip. There are things like not bending forward, not crossing your legs, sometimes using a pillow between your legs when you're sleeping. And this is what we're trying to avoid. Here on the left, this is a hip that's dislocated. You can see on the right, the ball's in the socket where it should be. On the left, the ball has dislocated out of the socket. And so again, that's what we're trying to avoid with those posterior hip precautions and trying to avoid with posterior approach hip replacement. So, the next thing that I think is really important is talking about component position, getting the parts in the right spot. So, we talked about how you get down to the hip joint, how you do that surgery itself. But really an important part of it is if you get your parts in the right spot, if the parts are angled the right direction, they really shouldn't dislocate. So, the guy that trained me, my fellowship director, did almost 100% posterior approach hips. And he really very rarely had a dislocation. Why? Because all of his x-rays were really perfect. All the cups were right like that looks here on the right down to this teardrop area, right about 35 to 45 degrees off the horizontal and tilted forward about 15, 20 degrees or so. But the challenge is with a posterior approach is, if you're really good and you've done 10,000 of these, then great, you're going to be pretty accurate, but you're still kind of guessing. You're using surgical landmarks. You're looking at where the acetabulum is in space, where certain ligaments are, and say, all right, well, we think we're pretty close right here. but you don't really use live x-ray. You can try to use live x-ray, but because the patient's laying on their side, you have a really hard time of getting an accurate x-ray. And so when I do posterior approach, I very rarely get an x-ray because I have a hard time making sense of what I'm seeing here. And so when you look at, we'll kind of go back here, when you look at these two pictures, you know, the hip here on the left, that's a little bit more vertical than you'd like. That's probably around 60 degrees vertical as opposed to 40 degrees where you'd want it. So I would say, well, looking at that hip, well, that thing was probably prone to dislocate, not necessarily because they had a posterior approach, but because the parts weren't in an ideal spot. And if you look at the right hip over here, you'd say, yikes, that one's actually pretty vertical too. It's kind of lateralized. It's not down to the teardrop, and it's not facing towards you at all. It's really pointing directly to the side. So that's something we call anteversion, which is also important in reducing dislocation risk. So I'd say both these hips are at risk for dislocation purely based on the component position. Leg length inequality is something else that we worry about, right? So this is a hip replacement that was done by another surgeon's patient came to see me, really worried about his right hip. His right hip was painful. But when we look at him, his left hip was quite a bit longer than the right. And when we look at this, you can see that this line that references the pelvis here, it intersects about the middle of this bump out down here. That's called the lesser trochanter. And on the right, you can see it misses it entirely. And so that left leg has been stretched out quite a bit compared to the right. So that's a leg length inequality, and that's about 8 millimeters. That's a significant leg length inequality. And again, that's something else that through the posterior approach, you're kind of laying on the side, you feel the knees, you get a pretty good idea, but it's not super scientific. It's really just feeling it. Again, if you've done 10,000 like my fellowship director, he was pretty spot on. He was pretty good. But this patient, his surgeon probably didn't realize that he was lengthening his leg, or if he did, again, that's a pretty substantial mistake there. So that's the old school hip replacement, and fortunately, it's come a long way since then. Again, I think the biggest thing, the biggest advancement is how we do the procedure now, right? So that's the anterior approach, direct anterior approach, and we'll talk about that a little bit in a second. I think templating is really important. That's really just planning and thinking about your surgery ahead of time. And I think templating and the direct anterior approach go really well hand in hand because we get to use live x-ray when we're using the direct anterior approach. You're laying flat on your back. We use a special table, but we get to bring this x-ray machine in, the live C-arm, the thing that shoots x-rays, and if we don't like that x-ray, move it over to another x-ray and shoot another x-ray, and you can even use live fluoroscopy if you need to. And so we get a lot of that immediate feedback of whether the parts are in the right spot or not. Multimodal pain control is equally as important as the approach. I think that alone has made a tremendous impact in, one, how much pain you perceive after, and two, how quickly you can get up and get around, which also helps with other things like minimizing blood clots and minimizing infection risk because you're getting out of the hospital sooner. We definitely have some techniques in minimizing blood loss. And again, this has definitely become something that is even an outpatient surgery now. So the direct anterior approach, I stole this picture off the internet somewhere. This is really where your incision is here. There's a muscle called the tensor fasciolata muscle here on the side. There's a muscle called the sartorius muscle here in the front. They're innervated by two different nerves, and we go right in between the two. And so by doing that, you're not cutting through the butt muscle at all. You're not coming through any muscle at all. You go in between that interval, you come right down onto the hip joint, you're right there. So this graphic from the internet says there's a smaller incision, faster recovery, and less muscle trauma. I would disagree with the smaller incision. I think the incisions are probably about the same. I could do a posterior hip through a really small incision, but it's not really about the incision. It's more about that muscle trauma. It's more about not dislocating the hip when you're doing the surgery. It's more important about not taping down those stabilizing structures of the hip. And I do think that there's a faster recovery because there's less muscle trauma. So again, you're not damaging the butt muscle. So it's not really paralyzed. You're able to stand up easier. The ability to do stairs is easier. I found my patients get off the walker sooner. When I came out of fellowship, I was doing probably 50-50 anterior approach, posterior approach. And really quickly, I just switched to entirely anterior approach. And it's because the anterior approach patients were all doing a lot better. I found that they had better pain relief and function at that early 2-week period. Some of them even longer than that. And I think if you actually look at the research, research where, again, my fellowship director who's done 10,000 of these things through a posterior approach, you compare that to somebody who's done a lot of anterior approach hip replacements. There's definitely quicker recovery early on, but probably no difference long-term. Again, if you're one of these guys that does a ton of them. But again, in my hands, early on, I very quickly turned to anterior approach because all my patients were doing better. So that's the reason why the patients like it is they have less pain. They're able to get around a little quicker. They don't have to do therapy. They just, they certainly feel better. The reason I like it is, one, there's a lower dislocation risk. That's because, again, we're not dislocating the hip to do the surgery. We're not taking down these stabilizing structures. But more importantly, we're using live X-ray. Whoops. We're using live X-ray to put the parts exactly where they need to be. So I sometimes tell people, look, it's not that I'm special or anything. Like the X-ray always looks perfect, but it's not because like I'm an amazing surgeon that always knows exactly where it needs to be. It's because we're cheating. We use live X-ray, we get the machine in there, and we put the part where it needs to be. And if it's off a little bit, we fix it. There's no guessing. There's no pointing to the corner of the wall, which at the posterior approach, you aim at the corner of the wall. You try to say that's pretty good. That's about 15 degrees. That's about 40 degrees. That's where we want to be. There's none of that. It's, you know exactly where the parts are as they go in. So I don't even care what the X-ray looks in recovery because I know it's exactly perfect when we're doing it. So again, there's no malpositioned parts. They're not the wrong size. They're not oversized or undersized. They're not too far out. They're not too far in. And really, we get to match it to the template. We do all the thinking ahead of time. We'll talk about the template here in a second. But we have the ability to make those leg lengths perfectly equal through that X-ray. We can draw those lines that we were looking at before. And if we see that one leg's longer than the other, well, we know about it and we can do something to address it. So this is actually a picture of a hip replacement that's being done. And we have this grid system, and there's lots of different ways to do this, but really these lines that go across here, these are straight lines that reference the pelvis. And this one line here, that's 35 degrees. And that line right there is 45 degrees. So we put the cup in, we put it right in between those lines, that's 40 degrees. So this isn't really rocket science, right? I mean, you don't, you make sure the cup's in between the two lines and your cup is exactly where you think it should be. It's tilted forward just a little bit. It's not looking perfectly flat like that other X-ray was. So I know, I'm very, very confident. We're halfway done through this hip replacement. I know that that part's perfect. This is later in the case when we've done the stem side, and now we're looking at the leg length. So we can look at these lines, those same lines that we had drawn earlier, and said, oh, look, that the lesser trochanter is way high on this side and way low on this side. Well, look here, we can look and make sure that those lines are perfectly where we expect them to be. So this person's cup is in a perfect spot, their stem's in a perfect spot, their leg lengths are perfect. We're still in the surgery at this time. So if there's any issues with any of that stuff, we can address it then. So again, for me, that's what makes me feel great about it, is that I don't have any worries at night that, oh, I hope I did this right, or I hope I did this right, because I know what's going on at the time of surgery. And if there's a problem, we can address it. So this is, again, a patient where the left side was longer than the right by about 8 millimeters or so. And we went back and we said, look, we want to make those legs equal. It's off now, we want to make it equal. So that was his pre-op. Here's his post-op X-ray. And again, now it's perfectly equal. And how do we do that? Well, this was not a guess, right? The left side was probably a bit of a guess trying to get those leg lengths right, and we missed. Or not me, but again, it was missed. On the right side, we were able to make it perfectly equal. So how did we do that? We did it through the live X-ray, making sure the parts are right, but also planning the surgery ahead of time. And so that's what templating is. What that means is that we use overlays to kind of think about where we would like the parts to be ideally. So again, ideally, you don't want that cup to be way out to the side. Ideally, you don't want that cup to be really vertical. You want it to be at this position right here, which is right down to the teardrop, about 45 degrees off. And when we do this measuring here, this is kind of a faded out X-ray, but we can actually measure that. And it says that it's 8 millimeters short on the right side. And so we plan to lengthen it by 8 millimeters on the right side. So with putting the parts in these positions, we're going to lengthen that leg by 8 millimeters. And so when we do his surgery, if you just follow that plan, that's exactly what's going to happen. Now, again, you do have the double check, right? You can go back and say, ooh, it's a little bit long, it's a little bit short, let's adjust some things. But templating is really important because you do all of that thinking ahead of time. You don't have to spend hours and hours trying to futz with it in surgery. You get in, you get out, you make it perfect the first time around. And I think that too helps with your recovery. This is another example. This actually is from 6 weeks ago. I just saw this lady back yesterday, I think. So smaller woman, smaller parts, kind of a high offset stem. This is why we template, because not every stem fits every patient. But for her, again, that final X-ray looks really similar to a template. So again, not necessarily that I'm special or anything. It's that we've thought about it ahead of time, and that we really just executed the plan that we thought about. So again, pre-op, post-op, pre-op, post-op. Really just executed that plan, right? And of course, that's, when we start doing more challenging cases, it's even more important, right? This is actually a pretty young woman that had this congenital deformity where this hip is really short and obviously doesn't look like a normal hip. She's really, really short on that side. But again, this is a hip that I do through the anterior approach because I get to cheat. And although her anatomy is all distorted and whatnot, I get to use live X-ray to confirm that the parts are exactly where we want and the leg lengths are where we want. And so that's her immediate post-op X-ray, and again, looks really nice. And so again, I like to think of that intraoperative X-ray as live templating, right? Again, we get to think about the surgery ahead of time and kind of plan and think about what's ideal for the position of those parts, but then we get to confirm it intraoperatively. So this is another patient. Right hip replacement was done in central Pennsylvania. And if you look at this, you'd say, oh, that cup's pretty darn vertical, 70 degrees vertical. That's well out of the safe zone that we would say. And if you just look at this, whoever did the left hip, I think did a very nice job. That cup's in a really good spot. It's about 45 degrees off the horizontal. It's tilted forward just a little bit. And it's the appropriate size. It kind of fits his acetabulum well. On the right side, this cup is huge. It's way too big for him. It's too lateralized. It's too vertical. It's actually too anteverted. And so predictably he dislocates, and he actually dislocated, he came into the ER and he dislocated like 4 times in 2 weeks or so. And so I actually had to do him as like an add-on case instead of like a scheduled thing. He was so unstable and dislocating so much that we had to go in and fix that. So again, for me, I really like the live X-ray. So I mentioned I do a lot of posterior approach revisions. I am doing more and more anterior approach revisions specifically for the live X-ray. So we took his cup out. You can actually still see his stem. We left his stem there. But we get to ream out. That's the reamer that prepares the acetabulum. And that reams right down to where we want it to be. When we put the cup in, we're putting that cup exactly where we want it to be. Again, there's those angles there of 45 degrees and 35 degrees, and that cup's right in between that. Instead of having that ton of anteversion where it looks like it's looking you in the face, it's about 20 degrees, 15, 20 degrees. Again, we check the leg lengths, make sure everything looks good there. And now with the final parts in, we can confirm that his cup's in a great spot and his leg lengths are right. So that's his pre-op X-ray there. We had been dislocating at least 4 times, and that's his post-op X-ray. It's got a bunch of screws and stuff because this is a revision. But again, I think you can appreciate that cup, which was kind of outside and pointed like that, now it's tucked down in where it should be. And he's about 5 weeks out, hasn't had a dislocation event since. All right. So I guess this is the point where I'd like to show some videos, just like some patient testimonial, if you will, about just kind of what it's like. So hopefully the videos come through well here. Let's see if I can replay it here. So this is a lady who's post-op day 0. So I went to check on her at the end of the day. This was actually, I think, 2 years ago. And so what she had said earlier, I kind of didn't start the recording in time, but she said that she had less pain then than when she came in with her arthritis pain. This is a guy who's 2 weeks out. So no cane, no walker, he's doing well. Not everybody is flying like this, but again, that's for somebody who's got good muscle quality, good muscle tone, you definitely don't expect a limp or, you know, certainly some people are still using a cane at that point, but he certainly was flying. And then, you know, I do a lot of patients that have had a posterior approach on one side and we do their anterior approach. So that's this patient right here. So that's a really common thing that we hear. I don't know if that sound made it through or not, but basically he was saying that, you know, posterior approach, again, if you get the parts in the right spot, the hip replacement ultimately is going to function well, but you're going to have to pay the piper in terms of cutting through that butt muscle. So his ability to move the leg and get up and stand up was a lot easier after his anterior approach. And I've probably done 80 or so people that have had a posterior on one side, we do their anterior. And I'm probably 75 have liked it better and 5 maybe haven't for one reason or the other. So again, a video sometimes is worth 1,000 words. So that's all about like anterior approach stuff, but that's not the whole thing. Again, I think if you talk to somebody who's had, you know, hip replacement done, regardless of how it was done, and there were some people a long time ago that were doing anterior approach in, you know, like the early, or I guess late 2000s, like 2008, 2009, they still spent 3 nights in the hospital. They still had a hard time with pain control. And so that's another change. Multimodal pain control. So what that means is we don't just give you lots of morphine. Morphine is bad for lots of reasons. One, it doesn't control your pain well, but two, it has all these side effects, right? It causes nausea and vomiting. It makes it so you can't poop. It makes it so you can't breathe. It makes you itchy, makes it so you can't pee. So these are all things that you need to do to like feel normal and get back to your normal activities, right? So if you can't pee or you can't poop, you're gonna have a hard time getting out of the hospital. You're gonna have to stay another day or two in the hospital. If you're too sleepy to do therapy, same thing. You can't get out of the hospital. You can't do what you need to do. So really, opioid medicines are something we try to avoid. And what multimodal pain control is looking at the pain pathway, right? The pain is not just in your brain, right? Pain is the nerve endings in the local tissues, inflammation in those local tissues. There's lots of different types of nerve endings and receptors. And there's lots of different areas in which that nerve sends that signal back to your brain through your spinal cord. And so what multimodal pain control is addressing pain at different levels using different medicines at different receptors to address that. So first thing we do is, one, we give you a bunch of medicines even before we start surgery, because if pain kind of gets out of control, well, then it doesn't really matter that we've given you some medicine because it's not taking effect until too late. Spinal anesthesia is one of the main things that we start with. That means that we get a shot in your back and you go numb from the belly button down. It's kind of like an epidural, but a lot stronger than that. I mean, you're completely paralyzed, completely numb. And so when you do that, that's beneficial for a couple of reasons. One, you don't have any pain, right? You're completely numb. Even after surgery, you wake up and you're completely numb. Two, you don't require a ton of anesthesia to knock you out. We still give you medicine so that you take a nap, just kind of like having a colonoscopy. But you don't need a tube down your throat. You don't need a machine breathing for you. And you don't need all this medicine to control your pain, which ends up making you hungover and nauseated afterwards. We put numbing medicine at the surgery site, really around every little muscle group and everywhere that we know that there's nerves around, so that when that spinal wears off, you still have some numbing medicine taking effect. And then we use at least 4 different medicines together. We use Tylenol, which doesn't sound like much, but it works really well on this particular receptor. And then we use Celebrex, or an anti-inflammatory of some kind, which doesn't sound like much. Most people have tried that and it's not working for their arthritis pain, but that works on this little area. And we use Lyrica, which is a nerve medicine. We don't use a ton of that, but we use that a little bit preoperatively, and it works on your nerve pain. We use Tramadol, which is technically an opiate, but works on a different receptor. And then we do have breakthrough narcotics if we need to. That really blocks all those different receptors. And so there's been a tremendous reduction in narcotic usage when you do that. And so definitely better patient satisfaction because you're not in so much pain. And we definitely get you out of the hospital a lot quicker. So I remember being in residency when we implemented multimodal pain control, because again, I was that guy that was on call for 40 patients in the hospital that all had hip and knee replacements. And I was getting calls all night long that Mrs. Jones is in pain and needs more morphine, right? Well, when we did that, I remember because all those calls stopped. We weren't getting calls in the night because people had their pain that was better controlled. And so again, that's made a reduction in length of stay, improved patient satisfaction. And again, you're not having all those side effects from being doped up on morphine and can't pee and can't do your therapy and whatnot. We talked about having to require transfusions before. Transfusions are bad. Even if it's your own blood, because it has to be clean, it causes immunosuppression, and it puts you at a higher risk for infection. So we really want to try to avoid that. So there's been a couple of things that we've done to reduce your risk for blood loss, or the amount of blood that you lose. Tranexamic acid is a medicine that we give you before and during surgery, and that it doesn't cause blood clots, but it prevents the blood clots that you naturally make from being broken down. And so that means that you lose a whole lot less blood during surgery. Also after surgery, we worry about blood clots, especially if you're in the hospital for 3 days and you can't walk because you're all doped up on the morphine. We used to use really strong blood thinners. And so if you do this big surgery and then we put you on a blood thinner, you lose more blood. Then you need a transfusion. This is just a bad cycle. So we try to use aspirin for blood clot prophylaxis now. And there's more and more and more research coming out that says that that is more than enough for people that are low risk for blood clots. And then again, there's minimally invasive techniques. You make the incision that long, it takes you 3 hours to do it, you're going to lose a lot of blood. If you make the incision that long and it takes you 45 minutes, you're not going to lose that much blood. You don't need a transfusion. So I can't remember the last time I had to transfuse a primary hip replacement patient. Revisions are a different story, but first time in with no problems, we don't even check your blood type because you're not going to need it. Just talked about tranexamic acid and how that's good. Modern wound care, again, I think that's another thing it's maybe not that like groundbreaking, but it's certainly important. So again, if we're sending you home either the day of or day after surgery, it's nice to have this bandage that doesn't have to come off. We stole that bandage from the plastic surgeons that really care about respecting the soft tissues, and We actually use that same kind of bandage for ostomy sites that are open for a long, long time. So that bandage can stay on for the 2 weeks or 10 days that we want it to be while you're healing and waiting to come back for your post-op appointment. I like to seal the wound with glue and sutures underneath the glue, so that we've separated the inside from the outside environment with the stitches and the glue, and then also with that bandage that was put on at the time of surgery. So if we do that surgery quickly and efficiently and cleanly, everything's sterile, we glue it shut and put that bandage on, and that stuff doesn't come off until the wound's healed in 2 weeks. One, you can shower and you don't have any problems with it. And two, it's been kept sterile for 2 weeks, and so the chance of infection is really low. And then discharge to home is really important. We've kind of had to harp on this a lot less, but even a couple of years ago, we still have people that want to go to a rehab facility. That's the last place that you want to be. Certainly with coronavirus and everything, we know that's not a place that you want to be. But as an orthopedic surgeon doing hip replacements and knee replacements, we worry more about bacteria than viruses. And that's also where all the bacteria are, right? There's bacteria that lives in the hospital and lives in the nursing home and lives in any healthcare environment that's nowhere else. And your home is probably the safest place to be away from that stuff. So we know that if you are discharged to home, you have a lower infection risk by 3 times. You have a less readmission to the hospital risk by 3 times, because you're just staying away from these hospital-acquired infections. If there's somebody who, again, 15 years ago, rehab facilities were full of hip and knee replacement patients. Now they're full of people with pneumonia and diabetic feet that you really want to stay away from. So again, the goal is to try to discharge you home. So when you put all that stuff together, you've got faster recovery, you're not as invasive on the soft tissues, you're doing a better job controlling pain, you're not losing as much blood, you got these bandages that can stay on for 2 weeks. Really that comes down to, or that kind of equates to being able to do hip replacements as an outpatient. And that's definitely something we've been doing even for the past 3 or 4 years now, is outpatient hip replacement at our surgery center. Medicare doesn't let us do that yet, but I think we're allowed to do it in 2021 now. I have to double check that. But one of the silver linings I've been telling people about coronavirus is, I used to send maybe 20% of my patients home after surgery, and the rest of the 80% would stay one night in the hospital. And now, more and more people are motivated to get out of the hospital. And we haven't really changed anything, but I'm probably sending 60%, maybe higher than that % of my patients home the same day now. And again, they get to sleep in their own bed. They're not having beepers and buzzers keeping them up all night. It's definitely the future of hip replacement. That's definitely not something that's going to change back even after the coronavirus is gone. So what to expect in terms of the recovery? Surgery takes about 45 minutes or so. We put that sterile waterproof dressing on at the time of surgery, and we don't want that taken off. If you have issues with the bandage, then we need to address that. That's not something we want your home health nurse or your friend or your family member taking care of. In the hospital, that spinal is going to work for about 3 or 4 hours or so. So you're going to be really comfortable during that time. But when that starts to wear off, we want you to get up and walk on it that day. And again, as long as you cleared PT and you're going to the bathroom and you're keeping your food down, you can go home. And so most patients are deciding to go home the same day or the day after. And again, we send you home with those same multimodal pain medicines that you had in the hospital. You get to go home with those too, along with the blood thinner. So for the first 2 weeks, we really just want the wound to heal. And you don't have to do therapy, you just walk and use it and whatnot. But there's no real restrictions. There's no posterior hip precautions. You don't have to cross I don't care if you cross your legs. I don't care if you bend forward. I don't want you doing yoga, right? I don't want you trying to bend your leg, behind your head. If it hurts, don't do it. But other than that, just kind of take it easy, walk, and let that wound heal. At 2 weeks, we want to make sure that the wound is healed and there's no infection. So I'm the guy that removes the dressing. If it's peeling off or you have a problem with it, call the office. We want to know about it. If you're having an issue with the wound or the bandage, again, that is something that we really worry about with infection. We want to know about it then. Most people have gotten rid of the walker at that 2 week visit, but if you're still using it, it's probably a good idea to get rid of it at that point. And again, no real restrictions or hip precautions. We then bring you back at 6 weeks to check another x-ray. And most people at this point, I'd say, are definitely through the worst of it. They're a lot better than what they started with. But you're still not done completely healing. It takes a while to build back that strength and stamina and whatnot. And so this curve is something I'll sometimes do is you'll get better really quickly, and then it takes you a while to get that last little bit. So, you can really do most jobs at 6 weeks. But, if you're a construction worker or you're lifting 50-pound bags of cement, at 6 weeks, you're not going to be ready to do that yet. It's going to take you a while to build back that strength. So again, when can you go back to work? If you're doing a desk job, you're just answering phones and working on the computer, working from home, 2 weeks, pretty easy, you can do that. If you're still in an office, but you're doing a lot of stairs and walking, and you're in and out of the office, probably more like 6 weeks. And again, if you're climbing telephone poles or you're doing heavy construction, maybe even 3 months. So again, just a brief recap, we talked about arthritis and what that is, how we treat it before surgery, talked about surgery itself and some of the advancements there, and the expected course. And so in conclusion, again, hip replacement's always been a great surgery, but we've really taken it to another level with some of these modern advancements. All right, that's all I got. I know there were a bunch of questions there. Let me see if I can stop screen sharing there and go over some of them here. Okay. Let's see, we got like 10 more minutes, so we can keep going. Okay, so first question, my right hip was done anterior 3 years ago. That leg is shorter than my left leg. I'm having my left hip done in 2 weeks. Will my legs be the same length? Short answer is good question for your surgeon, right? It's actually kind of hard to shorten a leg. It's very easy to lengthen a leg. If you shorten it, the whole thing that you're changing is the muscle tension. So if you decrease the muscle tension, it's more likely to dislocate. So the better question for your surgeon. Sometimes we can shorten the leg a little bit by adjusting things, but you also don't want to zig for a zag. If that leg's shorter because you broke your femur a long time ago and it healed really short, well, we don't, or healed long or whatever, we don't really want to zig for a zag. So it's hard to shorten a leg through hip replacement. Talk to your surgeon. He should be able to give you a good answer for that. The next one is, would every case be eligible for anterior surgery? Why is posterior still being done? In my hands, yeah, pretty much. I think there's some revision cases that I really don't want to do anterior, just because it's really hard to expose or remove parts from the femur through the anterior approach. Everybody's a little different. And if you would have asked me when I came right out of practice, again, I was doing 50-50. So anything that was a little bit challenging, I said, oh, I don't want to do it anterior. I want to do it posterior. I felt more comfortable that way. And again, as I've kind of evolved and probably have gotten better at doing this stuff and have done, 1,500 or however many of these things I've done, you start taking on more challenging cases. And so again, for me, like that revision case that I showed you, even 2 years ago, I would have done that posterior, but I do it anterior now because I like that I can use live x-ray. So it's more of probably a me thing than necessarily a different outcome for the patient in that setting. And again, I feel more confident doing it that way. And certainly the patients enjoy, some of that early recovery. Why is posterior still being done? Again, I still use posterior occasionally for bad revisions. I think, if your surgeon has done, like Chris Peters, the guy that trained me, world famous dude, he's done 10,000 posterior approach hip replacements. He does a really, really good posterior approach hip replacement. There's a learning curve associated with anterior approach hip replacement. There are studies that say the first 50 cases that you do through an anterior approach are not going to go great. Do you really want to expose 50 of your patients to that? And fortunately for me, I did learn a lot of that stuff in training. So I was kind of doing it, going through that learning curve while I was, under another surgeon. But I don't know, I've talked to Dr. Peters in the past, and he's like, it doesn't make sense to me to expose my patients to that when I do an excellent posterior approach. So yeah, in my practice, I'm almost all anterior approach. But again, you could understand why somebody who's not super confident with that and is very confident with a posterior approach wouldn't want to do that. Is the template done prior to surgery? Yeah, the template's done prior to surgery, and Dr. Ramsey's doing your surgery, and I'm very confident that he's done your templates. He does a good job, so I'm certain that he does that. Can you speak on infections, especially after 2 weeks of surgery? That you acquired an infection that requires you to go back to the hospital, get beads inserted. What type of infection and how does that happen? Okay, so that's a kind of a, there's a lot to unpack there. Infections are probably the worst thing that can happen in joint replacement because the joint now has metal and plastic in it that does not have a blood supply. So, if you get an infection, the bacteria will stick to the metal and the antibiotics will not get to it. So if you have an infection that touches the parts, you have to have more surgery. If you get to it quickly, within 2 weeks or so, a lot of times you don't have to take those parts out. You can just wash it really good. Sometimes you put these beads in. The beads aren't really anything. It's antibiotics that are in those beads that hopefully resorb. There's not great data on the bead thing. If the infection's been there or it's stuck to the metal, then you actually have to take all those parts out and then put in what's called an antibiotic spacer, which is kind of like the hip replacement, but it's got a lot of cement that eludes antibiotics to try to clear the infection. And you have to go back and do a revision hip replacement. So again, you know, a lot of the stuff we do before surgery is focusing on trying to keep that infection risk as low as possible. We give you chlorhexidine soap to shower with. We check to see if you have bacteria in your nose and try to decolonize that. We try to keep everything super sterile. That's why we do that sterile bandage. That's why we do it as quickly and efficiently as possible. How does it happen? You can get an infection from the time of surgery if the bacteria made its way in there while the surgery is being done. Sometimes if the wound drains for a while, bacteria from your skin can get in there. There's lots of reasons for that kind of issue. I went to pre-op today and was told I could go home same day. I'm on Medicare. Who's giving me the right info? If your surgery is done at the hospital and you have Medicare, you can still go home the same day. I think that's all the questions. All right. Okay, Lisa, I don't know if there's anything else. Otherwise, we can kind of wrap this up.
I believe that's all the questions, Dr. Brothers. Thank you so much.
Great. All right. Looks like we kept on time too. Awesome. Thanks everyone for coming.